A good afternoon, everyone. I welcome you all to today's 63rd eco session. Our topic for today is viral hemorrhagic fever, VHF. As we all know, Uganda as a country has been prone to periodically to these viral hemorrhagic fevers. And of course, once they happen, it's a disease of public health concern, and a number of cases usually are reported on to be positive, and even lives are usually lost. Like the last outbreak that happened in Mubende as a region, where we saw in 2022, where we saw a number of cases coming in and turning positive, and also we lost lives, including our colleagues who are health workers. So today with me, we have experts who participated in the management of these patients and control during the outbreak, who will be taking us through, of course, the patient's care. That is the case presentation. Then we shall look at the clinical care of patients with VHF. That is management, diagnostic, looking at the lab tests that are done to confirm a positive case. Then the IPC, of course, the infection prevention control that are put in place, both at community and health facility level, to see that these recording is controlled. We shall also look at the emergency transfer of patient with VHF. So all these discussions will be taken through by the experts. So we kindly request you to remain active online, and you can also still share the link with a colleague to join the session. This is an important topic for today. Next on the agenda, we are going to have introductions. We have experts here and others will be joining us online. I'll start with myself. My name is Halimah Adam, a proud nurse with a passion in emergency care, working at Mubende Regional Referral Hospital, and also EMS coordinator for Mubende. I'm your moderator for today. This moment, I welcome our experts to introduce themselves. I think starting with my extreme left. Kindly introduce yourself to the audience.
Very good afternoon to the audience. My name is Dr. Saudah Namubiru, Kizito. I'm a clinical microbiologist working with National Health Laboratory and Diagnostic Services Department, commonly known as CPHL, Ministry of Health, Uganda. Thank you.
Thank you, Dr. Saudah.
Yes, good afternoon, colleagues. I'm Dr. Kenneth Kobba. I work with the Infectious Disease Institute under the Global Health Security Department. And I'm happy to be here.
Thank you, Dr. Kobba.
Good afternoon, members and our viewers and everyone. Dr. Mugarura Allan. I work with Mubende Regional Referral Hospital. It's nice to be here. Thank you.
Thank you, Dr. Allan. This moment, I welcome the experts who are online to also introduce themselves. Dr. Liz, are you there? Or Dr. Oumo, you can kindly unmute yourself. Our online experts. Okay. So as we wait for our online experts to introduce themselves, we may briefly move to the next session, which is pre-test. I request you, the audience, kindly to fill in the pretest. Just feel free. It is just for your session assessment. We usually do pre and post first. You may click on your screen on more in order to access the pretest questions. As we do our pretest, I request the audience to share with us their expectations for the session. I know as we logged in to attend this session, the number of expectations that we had. Let's kindly share through our chats, and I'll also give opportunity to a few participants to tell us what are their expectations for these sessions by show of hands. So after completing your pretest, you just click on submit, then you start sharing with us your expectation for the session. By show of hands, kindly tell us your expectations for the session. Others may share the expectations through the chats, and I will expect a few people to show up their hands and share with us, tell us their expectations. We have, I can see Lamwaka, Solin. Kindly unmute yourself and tell us your expectation for today's session. Thank you.
Good afternoon.
Yes, go ahead.
I'm expecting by the end of this session, should be able to
You're not able enough.
how to find out if there's an outbreak before it gets out of. Will we be able to identify the presence of a viral hemorrhagic fever in the community before 3, 5, or a whole family dies? Like, what are the first signs we shall look out for in the community?
Did you get the question? Lamaka, we didn't get you so well. Did you get it?
Yeah, she's trying to say how can we be able to identify it within small population
Okay.
before it spreads.
All right, thank you. Your expectation has been noted by the participants and will be answered by the end of the
Thank
session.
you.
Welcome. Any other participant? So through the chat, I can see someone is expecting to know what were the results of the NBP. Is it a 134 antibody that we used on health workers in Fort Portal and Entebbe? It was a pilot drug. So that has been captured by the experts, and they'll be taking us through that as they present the topic. Any other expectation? So if there are no more expectations, someone has posted, I would love to know about the fluids of choice in management of Ebola. That has been noted by the experts. Thank you very much. So at this moment, I request we go to the next session, which is case presentation. Just continue sharing your expectation through our chats or Q&A. The experts will be noting them down. At this moment, I request our next presenter, expert, who is going to take us through the case presentation. Dr. Allan, over to you.
Good afternoon once again. We're going to pick out one case presentation as of interest. As a slide share comes up, we realize that Ebola was not segregative of age, sex, or even status. So any person can still get Ebola, irrespective of how old you are, what sex you, or even ethnicity. Looking at a slide share, I hope everyone can see. I'll try to jump to the summary of almost the biodata and everything. Yeah. The initials are HUS, so 16-year-old female, brought in by EMS ambulance, following a 2-day history of vaginal bleeding, vomiting, fever, and generalized body weakness. These were the complaints the person had. When you look at further digging in, the air was clear, the person was able to breathe. There were no secretions, nothing. There was difficulty in breathing. Respiratory rate was 30 cycles per minute, and SpO2 was 80% on room air. Here we had to intervene and give oxygen therapy via nasal prongs, which increased it to 93%. And saturation, there was mild pallor, there was hypotension, and BP was about 80 over 45 millimeters of mercury, and the capillary fill was less than 5 seconds. Here, the interventions went for was rigorous lactate and IV tranexamic acid. Then, when we follow that fusion mnemonic of sample, look at the signs and symptoms. We had the PV bleeding, we had the fever, which was above 39 and above degrees Celsius, and the vomiting. There were no known allergies. The medication from the history we took, the patient was not reporting any history of medications. And we had the past occurrent guide, which was that she was a PG at 9 weeks of amenorrhea. And last meal was not recorded because she was vomiting. And the events also were unknown. Next slide, please. Okay, our problem list. Now, this was after interacting with the patients. We had hemorrhagic shock, so the bleeding. We had hypothermia. You saw the temperature. We had dehydration, so the vomiting. She also suffered an abortion. Then there was epistaxis and blood diarrhea, followed by malaise. Now, when you look at the follow-up, things that we did to counteract, notice I'm trying to go through a summarized way to show how not to go in step by step. An MVA was done. Like you saw, there was an abortion. So the manual administration was done. Patient was then transferred to the ETU on the 2nd of October. She was transfused with 2 units of O+. Then we gave ceftriaxone IV, metronidazole, paracetamol. Then we also mixed the fluids. There was Ringer's lactate and normal saline. And then there was IV tranexamic acid to counter the bleeding. Then also, as during their stay also, we had to use IV artesunate together with the tabs. And then the IM vitamin K to counter the bleeding too. Now, you will notice the patient was transferred from an accident and emergency to the ETU. So while in the ETU, the patient was given supportive therapy to counter the problem lists, especially the fluids, for dehydration and antibiotic prophylaxis. However, the patient had a longer stay than expected, up to 14 days, as the repeat PCR results delayed to lower the CT values. We normally consider CT values to discharge patients. So even if the patient is clinically okay, but the CT values are still high, we still maintain them until we have lower values of CT, which would therefore say, therefore someone converts to being negative. I think with that, that will be the end of our case scenario. Thank you for listening.
Thank you so much, Dr. Allan, for taking us through the case presentation. And at this moment, I invite a few reactions by show of hands. Other questions, kindly, towards his presentation, kindly post through our chats or the Q&A. It will be responded to by the expert. Thank you very much. Yes, I can see Mawayne, Eric. Just unmute yourself and ask your question.
Thank you, Dr. Allan, for the presentation. I see there are a lot of emergencies in your problem list. At what point was it recognized this could potentially be Ebola? And when did people think of PPE, personal protective gear, to protect the health workers and even the patient? At what point did you suspect that? And also, were you suspecting septic abortion? What sort of abortion was that? Because you said MVA was done, how did the team arrive to that conclusion that this was an abortion? Thank you.
I can have two more people. Then we respond to the questions. Hissa Maljan, kindly unmute yourself and ask your question. Thank you.
Okay, thank you so much, Dr. Allan, for the case presentation. It was so clear. But my point is on how you arrived to the diagnosis of Ebola, because I really wanted to see how you came, the diagnosis, the way you protected yourself, like how to prevent Ebola, like how to prevent the health workers from contracting the Ebola, because that's our point of focus, the IPC. That's where I'm so much interested in. I wanted to see how you arrived to the diagnosis and how the IPC was carried out. Thank you so much.
Okay. So I think Dr. Allan, you can now respond to those two questions.
Okay, thank you very much. I'm sorry, I'm not going to mention names by the questions. I will just highlight the questions, and then you'll notice I'm responding to yours. Now, the person who started with CT. CT is a short form for psychothreshold. You'll notice the lab people will tell you what goes on, but these are things they use to carry out the PCRs. And for using a layman's language, these are a number of cycles that you go through to detect an Ebola virus. So the lower the CT values, that shows lesser quantity of viruses, which is a good thing. So if, let's say, the cycles have to be 10 to detect maybe 2 or 3 viruses, and then the other has to do only 2 cycles to detect 2 or 3 viruses, the one who does 10 is better off than someone who needs just 2 or 3. That's the bit I can share. The experts in lab will give you more. Then, at what point did we have to determine this was Ebola? One was the obvious one. We were in the times of Ebola. October was close to September when we detected the first case. So we had to be on alert for everything. And then when you look at how, like I said, the patient was brought in by EMS. Now, before EMS would bring in, they would first see if the patient meets case definition. Case definition forms would be filled, signs and symptoms would be recorded, and majorly any bleeding would be considered as a case definition, as a case defining symptom, which would have to wear a PPE, follow the protocols, and then investigate further. And then lastly, on the first day, she reported that the accident emergency, a PCR test was taken, and we noticed PCR tests would come in 24 hours. You notice even the patient was transferred to ETU after 24 hours. By then, we had already confirmed it was Ebola. But still prior to that, we already put operating procedures whereby any bleeding, any person meeting case definition, you are supposed to be in PPE while touching them. Then when it comes to abortion, this was entirely history. As you notice, the most definitive diagnosis, the most diagnostic criteria would be the ultrasound scan, which was not readily available. But just me asking when was the last time you had your periods would point you to suspecting pregnancy, and then still go further. While we're still giving care and everything, some products of conception were expelled, which also pointed us further to the abortion. And you also know, I didn't mention it, but one of the things we organized, there was a minor theater at the A&E, which was segregated from the general care and treatment of the hospital, which helped us do the MVA without infecting other clients. And then lastly, we also tried to do history, and one of the contacts was one of her spouse who we had during the care. Then diagnosis of Ebola, I think that one I will entirely leave it to the experts. I will not respond to this one. Then IPC, I already mentioned some. And like I said, I don't want to preempt what other people are going to unpack. So I'll leave it to the IPC people to give you the nitty-gritties of the IPC. Thank you very much.
Thank you very much, Dr. Allan, for responding to those questions. As Dr. Allan said, some of your concerns will be, of course, answered by the experts as they take us through in detail, concerning the topic. So I think we are closing this session now. We are moving now to the real presentation. We are going to start, going to go through the clinical care of patient with a VHF, and we shall start with management, then diagnostic, and later IPC. And at this moment, I welcome Dr. Kobba Kenneth to take us through the clinical care management. Dr. Kobba, you're welcome. But as he presents, he takes us through the presentation, I just remind you to forward your questions through the chats or the Q&A, which will be responded to by our experts. Thank you very much.
Thank you very much. And good afternoon once again, colleagues. In this session, we are going to share a little about the experience of clinical care in the ETU. So I'll start as we share the slides. Dr. Kenneth Kobba is my name, and I work with the Infectious Diseases Institute, particularly Global Health Security Department. I was part of the team that was at the front doing clinical care in the ETU for the Sudan Ebola virus outbreak in Mubende. I hope that by the time we end this session, all the team members will be able to recognize the symptoms and the different phases of the disease. As we've already seen from the case presentation, one of the ways that patients can present. We hope to talk more about this and be able to recognize the signs of severity and how you can know that from the way the patient presents that the outcome may not be good or may be good, depending on the care, but also how to provide optimal and safe care to patients presenting. And very important, the criteria know when to discharge for some of these highly infectious pathogens. The criteria of discharge is so important to ensure that you do not reintroduce the disease in the community. In our ETUs, the motto is always that we protect ourselves as healthcare workers so that we can save lives. And that is the principle, that the motto that we always re-echo during outbreaks as we respond. The overriding principle we follow in the ETU is to ensure that both patients and healthcare workers are safe. So the safety of everyone in that ETU during clinical care is paramount. And so it's the overriding principle. Do not do anything that puts anyone else at risk, or the patient, or the healthcare worker that is trying to attend to the patients. As we all know, ETUs are highly contagious areas, and all activities within the ETU, be it clinical care, be it cleaning, the hygienists, what they do, the data teams, what they do, it should be really handled with care. Yeah, next slide. So we are going to briefly talk about the clinical features, and we have features that present early, but also we have those that we usually see very late or later on in the cycle of disease in the patient. So in the early phases of this disease, you'll see very non-specific symptoms. And I think this is one of the reasons why we will sometimes see a delay in recognition of or discovering the outbreaks, because they present like any other disease. There is nothing that stops from a patient coming with fever in your clinic or in your hospital that you suspect to have malaria. There's nothing that stops them from having Ebola. So that's one of the things that we should be very aware about. So your key index of suspicion as a healthcare worker is so important. So things like general body weakness, fever, headache, pains in both the muscles and the joints, loss of appetite and nausea. We've seen patients presenting with a sore throat. They may have abdominal pain, mainly gastric. We had a number of patients, when the outbreak was declared, about 8 patients who were got already admitted on the medical ward were being managed for symptoms of gastric pain, things like PUD, but they had Ebola, acute gastritis, things like that. Diarrhea and conjunctivitis, all these can be in the initial phases, and they can continue throughout the presentation of the patient. Others in late can be things like the weight symptoms, the diarrhea and vomiting intensified. These can be bloody or non-bloody, confusion, patients going into shock, which can be both septic due to the high viral loads, or hypovolemic, as they are having losing a lot of fluid through vomiting and diarrhea. Internal and external bleeding can occur very late in the presentation. And previously, the misconception that was around was that these patients, because these diseases are called viral hemorrhagic fevers, the general misconception was that they will always present with bleeding. But now we know that very few, a smaller percentage, maybe 30%, may actually present with bleeding symptoms, as opposed to what initially was generally known. Skin rashes, seizures may also come in late. Like we've seen in the case presentation presented, the miscarriage can occur in a pregnant mother. So especially during outbreaks or in areas of high risk of having these outbreaks, mothers presenting with miscarriages should also be treated with a very high suspicion, especially when there's an outbreak. Respiratory distress can occur, and hiccups due to the electrolyte imbalances. So from the symptoms, you recognize that the Ebola and most of these VHFs will mimic other conditions that we already know. So, and this makes early diagnosis most times very hard. Most times you will see that people will wait until maybe the patient vomits blood or is having some bleeding symptoms before they can start suspecting this. So there are so many differentials that you can see. Could be malaria, typhoid. It could be another hemorrhagic fever, which is not Ebola. Meningitis, lepto, cholera because of the diarrhea and shigellosis. So it's quite a cocktail of differentials that we can have. And like I've said, the hemorrhage will occur in less than 30 patients of Ebola. So just for you to show you, we've had the case before, but this is another way a patient can present. The case we presented was through a miscarriage or an abortion. Here we are having a patient presenting with fever, headache, and those are the only two symptoms the patient had. This was a 19-year-old male who was coming from Kasan. And the only thing that would point you at the time that this patient has Ebola was the positive history of contact with a confirmed case. And the patient also had malaria. So it was very hard, especially for clinical work, for health workers who may just do one test and conclude. It was very easy for you to think it's just malaria. But when we did an Ebola test for this patient, PCR, it turned out positive, and the patient was admitted to the ETU. As you can see, the progress, developed diarrhea and vomiting later on, got respiratory distress, was confused, was seen wandering around the ETU in confusion and restlessness. You see, like almost 10 to 12 days later is when we are now seeing bleeding symptoms, and that's bleeding from the cannula site. And of course, the team in the ETU managed as the patient was presenting. Next slide. So you can see we have an early phase of the disease, which mainly shows the unspecific symptoms. Mild fever. The patient usually in this phase can eat and drink very well, and they're ambulating. When you go to day 3 to 4, the headache and the fever will intensify and maybe worsen. The appetite will go low. The patient is now having nausea. We may have an onset of diarrhea, about 3 bowels motions a day. Epigastric pain and hiccups are starting to come in, but the patient may be still ambulating, but a bit lethargic at this point. Next. Yeah, as we progress, we may start seeing a gastrointestinal phase where now we are things like diarrhea and vomiting are really intensifying. The team members who were in the ETU must have seen this, where the patients at some point, very many patients were having diarrhea and were vomiting, and the hygienists had to do a lot of work to clean. And this may be bloody, but not for all. The pulses in this phase are weak and fast. You may notice a decreased urine output because first of all the intake is low, but also at this point we are starting to see issues with the kidneys setting in, and other organs also setting in. The patient may be delirious, and at this point they are not so much ambulating as in the previous phases. Next. So mortality is really high in that GI phase because of hypovolemic shock. the patient is losing a lot of fluids. After that, we may have a terminal phase for those who may not improve, but also a recovery phase for the patients who end up recovering. And here, the fever and GI symptoms may subside. Of course, this all depends on how the clinical care is done. For those who may worsen and end up dying, they become confused and delirious, and renal failure may come in. You see very little urine or actually no urine at all, and the patient may eventually die. And always the aim is for the patient not to go to a terminal phase and try to manage the patient as much as possible in the initial phases. Next. Yeah, so because of a lot of fluids being lost due to vomiting and diarrhea, we see a lot of metabolic and electrolyte abnormalities in these patients. And this is something that we saw. Renal dysfunction due to shock and hypoperfusion. We will see an increase in creatinine and urea. These were being monitored in our mobile lab. The lab expert will talk later on about how they set up that lab. But we had a mobile lab next to the ETU that was set up for that outbreak, where we were requesting for these tests, so that we noticed a lot of patients having an increase in creatinine and urea. Metabolic acidosis was also very, very common in these patients with a lot of bicarbonates due to a lot of diarrhea that they were having. We did not see a lot of issues with sodium, particularly for the outbreak in Mubende. If you review most of the files, sodium was not really a very big issue. It can be an issue due to the losses that occur, but for the Sudan outbreak experience, it was not really an issue. The issue we had was more to do with potassium, and actually the issue we had with potassium was hyperkalemia and not hypokalemia. I think the main reason was due to most of these patients having renal issues, and hyperkalemia was set in. We did not have hypo as a very serious issue for us. Hypoglycemia has always been an issue with these outbreaks, and it's one of the things that you always really need to look out for. Previous outbreaks saw very many deaths due to hypoglycemia, which surely shouldn't be a case, as this is really a very avoidable cause of death. So these are really life-threatening and need to be monitored closely and treated as soon as possible by the clinical teams. Next. Yeah, so this is to further highlight what we saw. This is another example from a patient that we saw, the very patient that I talked about previously. And you can see the vitals that the temperature kept going up, and at some point it came down, but that was when the patient was really terminal. The BPs were relatively stable throughout the patient presentation. Not so much worry there, but you can see the respiratory rates and respiratory distress was really an issue throughout the outbreak in Mubende and Kasanda. You see the reds are mainly urea, creatinine, those are kidney issues, and then you can see the liver also coming in. But and also you can see the potassium shooting up for this patient. And this was a picture for very many other patients. And this is just an example for now. Next. Yeah, what are some of the things you look out for that we notice that are associated with high mortality? The very young children and very young children and the very old, not actually very old, but those above 40 were less likely to survive. We saw a lot of mortality in these ages, very young, less than 10, and then those above 40. Those with a high viral load, we were not really checking viral load, but we were checking the CT values as the previous presenter said. And for very low CT values, there was a lot of worry, and the chances of survival were lower for patients with low CT values. Patients who went into organ failure, of course, the clinical team, the physicians we had, and the whole team would try to manage these patients, but of course at a higher chance of not surviving compared to the others who did not go into organ failure. Time of presentation was an issue. In a way that patients who come late to the hospital and present late, they will come in those later phases. Someone comes when they're already delirious, they're already having profuse diarrhea and all that, compared to the patients who came with just say headache and fever. Those who presented very late were at a very had lower chances of survival. Pregnancy generally, because of the lower immunity and all that, I think we had about, my memory serves me right, we had about 2 or 3 patients who were pregnant. I don't remember any deaths were pregnant mothers there, and I think that's thumbs up to the clinical team that was there. But generally speaking, I mean, in other outbreaks, pregnancy has been reported as associated with the higher risk of mortality. And of course, those who had other comorbid conditions, especially like DM and things that give immune suppression. Testing for HIV is very important, as you have to follow the national guidelines there on management. Yeah, this is just to highlight what I was telling you before. You can see 0 to 9 and those above 40 high. Next. Yeah, that also just highlights the time of presentation. Those who presented very late, you can see about 55, over 50% case fatality as for those who presented 10 plus days after onset of the symptoms. Next. Yeah, that's a picture of the ETU. How you organize the ETU is very important for clinical care. First of all, it stops mixing of, you have to ensure that patients are not mixed. You have a clear section for those who are wet, those who are dry, those who are waiting for discharge, those who are symptom-free. All those compartments are very important. And a clear plan every morning, just like you prepare for your ward round, is very important. Also to hand over of cases for those who are not doing well, the one shift should hand over to the next to maximize efficiency in this environment. Next. Yeah, most of the treatment in this is supportive but aggressive in a way that GI fluid loss due to diarrhea and vomiting is very frequent, and so IV fluids. In Mubende, we would give all patients ORS, regardless of whether they had started the GI symptoms or not. But it was important that the patients are well hydrated from the word go. And also these are always adjusted with how the patient is assessed every day to know the amount of fluids to give and all that. But also the symptoms they present with: fever, pain, vomiting, hiccups, seizures. Each of those should be managed using the drugs we already have. We are not really very specific drugs that are given, but already the known guidelines we have for management of these symptoms for the different ages for both children and adults should be followed within the ET. Next. Yeah, like I said, give ORS to all the patients and encourage them to drink it. always assess to know those who are vomiting, those who are so weak to lift and drink on their own, so that you adjust and probably give IV fluids for those that need that. So constant assessment is very important. Next. Yeah, so patients unable, Ringer's lactate was our IV fluid of choice for these patients. This would always be adjusted based on the results for the electrolytes that we would always get on the daily or after every 2 days to know which fluids is recommended, especially monitoring potassium when giving these fluids. Next. Next. There are no clear, obvious guidelines for children, and often you will notice that the known Plan A, B, and C recommendations by the WHO, as used in routine care, may need some adjustment for cases where the patients are profusely having diarrhea, vomiting, and not eating. And so the clinical team and the pediatricians on site usually have to assess these patients, the pediatric patients, and recommend the fluids that should be given and the amounts, taking care not to overload the patient. The different metabolic electrolytes, abnormalities like acidosis, hyponatremia, and hypokalemia have to be managed. And you will notice that I'm not going into the details of these, and the reason is because there is no specific management for an Ebola setting. It's the usual management that we give, even in this case. So the gold standard is to monitor and treat as our recommendation says, where you have to give potassium chloride, you give that. Where you have to give sodium bicarbonate, you give that as per the presentation of the patient and the lab results. Yeah, consideration should be taken for co-infections. And for Ebola in Mubende, it came at a time when the number of malaria cases in the region had gone up. So what I remember is that what was done, that there was a drive to give prophylaxis within the region, which was done, and that kind of brought down the cases of malaria co-infected with EVD. But also for children, there was a surge in number of measles cases at the time, which also presents with fever. So there has to be care to know that these other conditions can also coexist with Ebola and any other VHF. SAFE and CIPRO are the commonly available and used broad-spectrum antibiotics for patients suspected to have other bacterial infections. And Metro was used for those who had GI symptoms. Yeah, the recommendations for malaria and HIV follow the normal treatment guidelines given nationally. So those should be followed also in the outbreak setting. Also, malaria, HIV, and TB should also be treated in the same way that is treated as per the national guidelines. Next. Yeah, so someone had asked earlier about the MVP and remdesivir. Healthcare workers should know that in a setting of an outbreak like this, especially for VHFs where we may not have readily available drugs that cure the disease, there is always a provision for compassionate use of certain medicines that could be useful to the patient. For the Sudan outbreak in Mubende, we used remdesivir and MVP 134. These were donated to us by the manufacturers. And I think these came in late because we had to get approvals from the reg for them to be used in this setting. So those delays in those processes meant that these drugs were acquired quite late. Only about 17.5% of the total number of patients that were admitted actually used these drugs in that outbreak. Of the 7 healthcare workers admitted in Fort Portal, 6 used them. They are mostly effective when they are started in early disease. The challenge we got is that most of the patients would present late, and so it was very hard to monitor to know the efficacy of these, mainly because from the manufacturer recommendations that they should be used in the first maybe 10 days, before 10 days, and most of them would present after 10 days of symptom onset. So that was the biggest challenge with these. Yeah, the special considerations about around pregnancy, knowing that you should always take history about the last menstrual period to know whether a patient is pregnant or not. Like I said, they are at a higher risk of complications, spontaneous abortions, as we saw, fetal death. I think we had a stillbirth where the fetus was found to be infected. Within that outbreak as well, but also to minimize healthcare worker exposure to blood and other blood fluids during management of these patients, especially during MVA and also delivery, where the healthcare worker may be exposed to a lot of blood. Next. Yeah, next. Yeah, nutrition is important, as some patients may be very weak and unable to feed on their own. So there should be special attention to what patients eat. It should really be a very balanced and protein-rich food that is given to them. The psychosocial team is very important, as this disease causes a lot of psychological torture and stress to these patients. So counseling and educating them is very important, and we really saw very good results when the psychosocial team was involved in their care. Next. Yeah, so lastly, as I conclude, it is always important to document information about this patient so that it's easily passed on from one shift to another. And we used mainly a whiteboard to always communicate who is severe, who has the CT values being high, and that. And the last thing is how to know who to discharge. The discharge criteria we used and it's usually used is if a patient goes 3 or more days without a fever or any significant symptom, we started monitoring, and you can see a significant improvement in the clinical condition. And if you notice that the patient is able to perform their activities of daily living unaided, but also importantly, regardless of all the above, the patient should at least have 2 consecutive negative PCRs, which we were doing when the patient is asymptomatic. So you would notice that sometimes the first 2 would be negative, and if you do the second and it is positive, then you can't discharge that patient. You again repeat after 48 hours until the patient has an undetectable viral load and the PCR is negative. Yeah, thank you very much. And I will hand back over to the moderator.
Thank you so much, Dr. Kobba, for taking us through that clinical care management, and that was elaborate enough. For the questions, kindly post them through our Q&A and chats. Will be answered by the participants as we all go on with the presentations. At this moment, I invite Our next presenter is online. That is the IPC expert, Dr. Elizabeth. Thank you for joining us. Kindly unmute yourself. You may introduce yourself to the audience and then take us through the IPC. Over to you, Dr. Elizabeth.
Thank you. Thank you very much, team. I'm getting ready to share my screen. Kindly confirm you can hear me. Can you hear me?
Yes.
Yes, we can hear you.
Right. I just wanted to be sure. My name is Elizabeth. Katwesigye has been highlighted, and I'll be taking us through the IPC section of this discussion. I work at the Ministry of Health and I support infection prevention and control. I was requesting to stop the video so that I can save on bandwidth. This short piece on IPC will be just to highlight the principles of IPC in the context of Ebola virus disease. When we were sharing out the communication, the flyer for this webinar, people were getting in my inbox asking, why are we talking about Ebola? Do we have an outbreak? And two things came to my mind, especially in relation to IPC, but also the case management preparation. One was, we do not train our soldiers in war. We train them early, we do drills, we equip, so that when there is war, we're ready to deploy. But also, in particular for Ebola, the outbreak start with that one patient that presents to a healthcare facility, health center, regional referral, somewhere in District Z with a fever, headache, and abdominal pain. And that's why it's very key for us to talk about these infections. As healthcare workers, we familiarize ourselves with the different care models, with what should be done so that we're able to direct these patients, but most likely stay safe. At all healthcare facilities, like I've mentioned, there's an opportunity, there is anytime a patient can come. Routinely, Ebola case management, the clinical care that Kenneth and Alan have just highlighted, will routinely be performed in a designated treatment unit or a designated facility for Ebola. But there is always that one patient that will present at the patients will come to a routine healthcare facility before a diagnosis is made. Hence, all our healthcare facilities need to have capacity to at least have early identification so that we can control at source and link to testing and safely transfer or offer care in a way that will minimize infection spread, but also improve the patient's outcomes. Ebola is a virus with a lipid envelope, and all classes of viruses that have a lipid envelope are very easy to handle in terms of destruction, because once the lipid envelope is disrupted with soap, chlorine, open environment, air, sunshine, this virus will easily be disrupted, which means that our basic IPC measures will be able to minimize the spread of Ebola, washing your hands, cleaning the environment, exposing in open air and the like. As we think about the IPC measures to put in place for viral hemorrhagic fevers, Ebola, any other infection, it's always key for us to think about mode of transmission, because that's what will determine the caution you put in place. And in particular for Ebola, it's really human-to-human transmission that amplifies the response. And most of the healthcare workers will get infected, usually early in the outbreak, when we are not suspecting these infections and hence not putting in place proper IPC measures. For example, keeping the patients from others by isolation, putting on the required personal protective equipment and the like, because that's, we have not yet suspected that there could be an outbreak. This is just an overview of this is one of the IEC materials we're utilizing, just to emphasize that it's through touching, getting in contact with fluids from an infected person, vomiters, blood, sexual intercourse, and the like. For facilities that have inpatient capacity, patients that come into the facility and screen negative for Ebola at admission does not necessarily mean that these patients are not infected. Then again, we need to think back about the incubation period of the disease we're trying to prevent. If someone was exposed in the community within 2 days to 21 days before coming to the facility, they could still be intubating. So even when the patients are on the ward and we're doing routine ward rounds, we need to ensure the precautions for IPC are in place. But also, as you're clocking patients and the patient is developing a fever, these other symptoms are coming up that were not present on admission, could mean that probably they were still intubating while at home, and now while they're in hospital, the symptoms have come on. So ongoing surveillance, not just checking at the gate, but as we go through the cascade of care. The role of IPC will not be overemphasized. Really, it's to prevent transmission, minimize as much as possible, and prevent transmission of infections. And the IPC measures really work at breaking this chain of transmission. I think all of us on this call have looked at this chain in one meeting, in one presentation or another. Just highlighting that at the back of our minds, as we're putting measures in place, think, where is this infection coming from? What is the organism? How will it move from point A to point B? What is the mode of transmission? How does it enter a human being? Usually through the parts that the president called the soft parts, and then you're able to prevent that. There is a susceptible host somewhere who is more likely to get infected than another. How do we put measures in place to ensure that they don't get infections? The different measures that we talk about for IPC, there is a hierarchy of these controls, and the larger part of the inverted triangle shows the most effective measures, and the lower part in red shows the least effective, and the cascade moves like that. So ideally, you would need to have if it was possible, you would eliminate, you would substitute the pathogens, but where it's not possible, as much as possible, to have mechanisms in place which we call engineering controls. And these really help isolate people from the hazard, your ventilation, your structures for isolation, to ensure that the infected patients or wherever you're suspecting infection, there is no linkage with the rest of the population. Administrative controls, these are changes of the way we work. How do you organize your screening and triage stations? Do you have appointments? Are we orienting healthcare workers? Are we screening and vaccinating those who are required to vaccinate? And then what we commonly go to, which is the PPE, really will offer you as an individual the least level of protection if it's being done when the other measures that are supposed to contain the pathogens higher up on the chain are not in place. So for example, you'll not have good protection if you're putting on full PPE, but you're not working in a place where you're properly screening patients and the like. Although in reality, we always invert the triangle, which is what we should stay off from. We always think about our PPEs and our admin, and we forget about the engineering controls, but we should really be thinking about the triangle on the left, the inverted triangle. The key components of Ebola case control, the clinical colleagues have already highlighted things around case investigation and optimized clinical care. And then IPC measures in the community and the healthcare settings come in place to ensure that these other processes are safe. Kenneth has highlighted care is beyond just isolating the patient. You actually need to go in, give fluids, take off samples, give nursing care and the like. So we need to ensure that we have preventive measures in place to ensure that we are minimizing infection. And of course, leadership is that key. We need to have a control system. We follow command, we follow guidance from the national level and the different levels, especially in the context of the outbreak, so that we're all following procedures in a systematic way. There are slight differences on how IPC considerations for the actual specialized units that are treating Ebola patients and the routine healthcare facilities, but there are still some standing principles in both of them. For example, we need to ensure that the standard precautions that we shall look at in the subsequent slides are utilized at all times, whether it's a facility that is treating Ebola patients or a routine facility is handling essential health services. Things around training of healthcare workers, orientation, supplies, and then ensuring that you have structures in place, a built isolation unit, what is the layout, do we ensure we have in lateral flow, do we have a clear place where the infected patients are handled and a green zone where the healthcare workers can safely do the other procedures that are not related to patient care. And then if you go to the Ebola treatment facility, this will be looking at how do we organize our facility to ensure that we are able to do functional screening, but we are also able to have a hold and keep the patients that are suspected to have Ebola as we wait either to transfer them to the next facility that is offering Ebola care or a place in our facility where Ebola care has been designated to be offered. For the Ebola treatment units, we shall have more detailed pre-deployment training and orientation sessions for the healthcare workers just to ensure that we're up to date with our IPC skills. But even for the general staff that are working in the non-ETU places, ensuring that there is that quick refresher to remind us about the IPC consideration, especially for that particular disease. These are the standard precautions which should be used by all patients at all times in all healthcare facilities, irrespective of the risk of exposure. So as long as we are doing patient care activities, things like hand hygiene, which is guided by the 5 moments, use of personal protective equipment. This is based on risk exposure. What activity am I going to do? What is the risk associated with this activity in terms of exposure? And what is the outcome in case I'm exposed to this pathogen? That's what will determine what PPE you're going to put on. For example, if you're going to give a vaccine jab during a routine setting, the risk of exposure to the body fluids will be available, but it will not be as much as if you're going to do a surgery. So you need some precautions that you may not need to do if you're going to do abdominal surgery for PPE. Safe injection practices, not reusing the injections, disposing them safely in the sharps box. That goes with the sharp safety, co-face etiquette. More importantly, cleaning and disinfecting the patient care equipment and instruments. And this goes beyond the surgical instruments that we'll think about. We're going to open up someone's abdomen. What about this BP machine and stethoscope we're using on every other patient? All those equipment, there should be an SOP in place to ensure that they are cleaned between patients. The healthcare environment, laundry and linen, waste management, that is looking at from the point of generation of the waste, minimization, segregation according to the categories, transportation, and then final disposal. Of course, for the Ebola outbreak, every waste that is generated in the treatment unit is considered highly infectious, but still we shall have to separate the sharps from the other waste. Aseptic techniques, risk assessment, very key, whatever procedures you're going to do. I just highlighted just a few of the standard precautions in the interest of time, but we can always have other sessions where we can do a deep dive in any, depending on the demand. If people feel like we may need to have more detailed discussions on actually how do we clean and disinfect patient care equipment. But for the purposes of this presentation, we're not going to do a deep dive in each, but just the key ones like hand hygiene, which is important, very effective, very easy to achieve. Recommendation is to use soap with water, any type of soap. And then alternative, equally effective, it's disinfecting with alcohol-based hand rub. Alcohol-based hand rub is easier to carry at the point of care. And whenever hands are not visibly soiled, then you can use that as your first option. Dilute chlorine 0.05 is only kept for when the other 2 options are not available. In instances where you require large volumes of activities that include hand hygiene, like especially in outbreak settings, and soap and water or BHR may not be readily available, but routinely we do not want to use chlorine on hands because of issues of causing excoriations and then exposing ourselves to more infections. This is for all of us to go and continue looking at the 5 moments when you perform hand hygiene. Just the key areas as a reminder, not only when you finish seeing a patient, but even as soon as you're going to see a patient to avoid transmission of infection at that point. Key to Ebola and to other highly infectious diseases, the key IPC considerations also include screening, triaging, isolation, and notification. We've had several questions about these 3 terms. So just a snapshot of each. Screening, our outcome of screening, that's the box that is in blue, is to determine if the patient is a suspect case of Ebola or not, as simple as that. You observe the patient, ask questions, and do non-contact temperature taking. And this will be guided by a case definition that is available, but also keeps being updated from different evidence. Like Kenneth was presenting some of the symptoms that were observed commonly in this outbreak. Probably bleeding was not very common, especially early in the disease. So the case definition will always change. And whenever there's an outbreak, keep looking out for the most recent case definition. Routine screening will not require close contact or physical contact. You can do it at a distance. There can be a physical barrier to ensure that you quickly pick out those that you think are suspected to have an infectious disease. On the other hand, triage is what we do routinely in our facilities. And the key outcome of this is to determine how sick someone is. We commonly use our triage algorithms. We have the colors for the patients that require emergency care and those that can wait. And this will require close or physical contact because you may need to take a pulse rate. You may need to do other closer activities. You may not be able to do it at a distance. Then finally, isolation is separation of a patient from others to reduce the risk of contact or spread. And the key outcome of this is the patient is transferred to an area where they will receive emphasis, testing, and further care, not just being taken to an area to be kept there. And this will definitely require close or physical contact. Screening is commonly performed at the entrance of the facilities or any other place that's, for example, at the treatment unit, at the entrance of that treatment unit, preferred to be done at the first point of care with the health system, usually at the entrance, which means that there should be a way to gazette of the facility to ensure that there's only one entrance. You can see in the demonstration here, there's a hand hygiene station, there's a physical barrier highlighted by those 2 orange bars with space in front. And this is for everyone, healthcare workers, patients, visitors, not just the patients that are coming in. This is the case definition that we're utilizing before that would guide us to pick out the symptoms, to think about the suspect, take your temperature, and be able to quickly pick out those that meet a case definition. Setting up a screening station as we go back to our healthcare facilities to look around how we can organize our space to ensure that there is a space that can be utilized for screening that has the green zone. The green zone is the safe zone. No infections expected there. It's where the healthcare workers will enter from, will work from, and will be able to keep a few supplies that are needed. And then the red zone where the patients will continuously come in, get transferred either the treatment unit or to the routine healthcare facilities. And those that don't meet case definition will definitely be sent to the routine healthcare facilities. Thinking around things like access, hand hygiene stations, we should be able to provide the toilet for these patients so that in case there is a suspect, they're able to have where they can do all other things. Personal protective equipment. This has been an area that has attracted a lot of discussions in prior outbreaks. So here we're just going to go through a brief principle, and if there are any questions, we can discuss them in the chat. The key to personal protective equipment, whether it's for Ebola or for any other disease, like I highlighted, is risk assessment. Always think, what procedure am I going to do and what is the risk associated with it? If you're going to insert an NG tube in someone, you know that they can easily cough. So you know that you need to protect areas around your face so that you don't get secretions of the patient falling into your mucous membranes. And then also think, what is the mode of transmission of these organisms? For a disease like Ebola, we know that there's contact. So even when you touch surfaces and you're not putting on protection, you're likely to get exposed into your hands, and then you can transmit to other patients. Very key for us is the correct technique for putting it on. The correct technique for putting it on is guided by the SOP, but the only way we shall learn it is by doing it. You don't want to be putting on a coverall for the first time when you're going to see an Ebola suspect who is convulsing, or Kobba has highlighted that we need to think safety first. But as we think safety first, let's put our procedures up to date by continuously practicing on how to put on this PPE to ensure adequate protection. And then more importantly, how do we put it off? Because you can put on PPE, you're protected. And if you're not following a good procedure to remove it, you still have a risk of self-contamination. I've just highlighted some few pictures here. Members can post in the chat what are some of the observations, but you can see someone's mask is in the forehead and they're putting on sweat gloves. So we're wondering what is the protection. On the left, the healthcare worker in red is putting on gloves, but then is on the cell phone. Someone is putting on gloves and is touching their face. So all these are things we need to think about, that even when I've put on PPE, I will not get ultimate protection unless I'm using it correctly. This was just to highlight that for Ebola, we are looking at risk stratification. If you're going to do anything that involves physical contact with the patient, any patient-related activities, transferring patients, we're going to look at transfer of patients. If you're going to get into close contact with them, you need to be putting on what we commonly call full PPE, full body protection, from the feet, the body, the head, the face, and the hands. And for people who are doing more invasive procedures like burials, cleaning, and decontamination, on top of the above, there will be need for heavy-duty gloves and heavy-duty apron, really to minimize the risk of exposure. And then for some things like screening, if you're able to screen at a distance, we talked about of 1 to 2 meters, you'll need very minimal PPE because you're not getting in contact with the patient's body fluids. But for any reasons where you do not need, where you need to get in close with the patient, for example, you need to assist the patient to move from point A to point B, you need to take off a sample. For Ebola, there's nothing like this is a small procedure, I'm going to do a BS. You need to have your full protection. And this is very key for us, especially who are working in healthcare facilities, that during an outbreak may not be working as Ebola treatment units. Look at the risk of exposure, and as much as possible, assess what you're going to do. And if you're not able to have this level of protection, then you offer minimal care at a distance as you notify for transfer at the next point, so that you don't become a hero. The PPE for isolation care, we've already highlighted it. I think all of us are very familiar with this picture. They cover really from head to toe. I just thought I would talk briefly about obstetric departments. They are not the only departments where we're likely to get exposure. Every department in the facility can give us exposure, but obstetric departments are some of the common departments that we all have in our facilities where there are higher risks of exposure to body fluids. Of course, surgical departments will also fall into this category, but all departments are at risk. But just emphasis for these departments where we anticipate routine exposure to fluids, rupture of membranes, blood. We just need to emphasize that routinely our standards for PPE and IPC requirements for routine procedures like delivery should be followed. Things like facial protection, every midwife and every healthcare worker who's delivering a mother should definitely have facial protection, either by face shield or goggles, should have a gown, should have long-sleeved gloves up to the elbows as much as possible, because you may not anticipate a retained placenta and you need to go in and pick it. Then foot protection, so that at least on a minimum, we have the required protection. Because, and also this is a key essential service that we have to continue even when there is an outbreak. For purposes of Ebola, for the mothers that are suspected to have Ebola, or the survivors, the people get Ebola and survive with an ongoing pregnancy because there are still risks of placental deposits of Ebola. Anyone who is a suspect, you need to be able to put on full PPE to conduct deliveries. And if not possible, then we should be able to transfer this mother to a site that can be able to deliver them, because this is an essential service, but also the risk of exposure is very high. Just briefly to highlight for us about the setup of the isolation units. The areas highlighted in green just show that we need to have a place for the staff, the kitchen, the storage, where we are doing the administrative things like Kenneth was highlighting, like our morning meetings and the like. But we also need to have a place where we are able to handle both the suspect and confirmed cases. And we're able to discharge them either, if unfortunately they've passed on, we discharge them through the morgue or discharge them home, and the suspects that are test negative are discharged home. So as we look at our facilities and think around setting up space, these are some of the principles we think about. What barriers can I put? How can I change the workflow so that we can have a safe environment for people offering patients, the Ebola patients and the like? This is just an example. I think most of us have observed this. On the left is for a facility that does not have any space which we can modify into an isolation, just to identify an area and say that everyone who be suspect, case definition, will rest here, give them minimal care, you can give them ORIs, anything that doesn't involve direct contact as we wait for transfer. And then for the facilities that are able to set up isolation, this is a kind of, can either be temporary or permanent. We have several SOPs that highlight the steps for donning and doffing, and a link has been availed in the presentation for all of us to take a look and practice. Then in particular for Ebola and other VHFs, there are other measures that we look at to really minimize transmission, especially in the community setting. And one of them is the IPC ring approach. In the previous Ebola outbreak, I think some of you saw members in your facilities decontaminating, doing assessments, especially it is where in areas an Ebola patient has been identified. And this could include the household, the community, and the healthcare facility where this patient, because you know, in our setting, patients will present to, I think Kenneth can hide it, remind me, but I think on average, patients had presented 2 or 3 places before they reached in the isolation unit. So all these places that the patient has passed through will be identified, and the use of identifying them is that you're able to offer quick IPC support to these areas, minimize transmission. And this will include the decontamination of the facilities to ensure that we are clean, the environments are clean, and the households. Do a quick setup of a triage and screening, because where a patient is coming from, they are likely others to be coming, and then they will come so that we can quickly identify them. Do an exposure risk assessment for the healthcare workers that came in contact with these patients, and the ones that have a high risk of exposure measures are put in place early, and then provide any quick IPC and watch support as required to that area to ensure that we minimize transmission of these infections. This is very key for us as healthcare workers as we receive these patients, ensuring we take proper records so that we're able to trace where some of these patients came from, even when the patients have passed on, and we're able to do all these measures in the community. The take home from this presentation would really be that for Ebola, every healthcare facility should be able to screen, have our case definitions available, have our non-touch thermometers available. These are calibrated. Screeners have been identified, and they're oriented in how to take the temperature and most importantly, take the temperature and the symptoms, but also interpret them. Because we've had instances where someone has been taking temperatures the whole day in the book, and there's been no clear output on actually what happened when the patient had 37, but for them, they've taken temperatures and have documented. Isolate as much as possible, transfer to the isolation area to ensure patients get maximized care, not keeping them around in a corner in our facility. Isolate them. Notify. I think you need to help and maybe meet the other participants. Notify so that these patients can be taken to areas where they are offering the care. And then we're going to talk about transport shortly, ensure that the prevention measures are still being upheld while we're transferring the patients. And then cleaning and disposing of waste, utilizing the appropriate PPE has been discussed. As we go to the end of the presentation, I would encourage all of us to think around preparedness rather than when we have an actual case, and have a guided, planned, systematic documented and monitored implementation of IPCs at different levels. This is just highlighting what has been happening. Like I highlighted at the beginning of this presentation when we put out the flyer and the question was, do we have an outbreak? So commonly we've always had our active engagements during outbreaks, but as you can see, we are still able to go out and build capacity in a time when there's no imminent outbreak. And for IPC, what does that mean for us? This just shows the IPC core components that we can always look at. Things around, we have our, is there any person in the facility who is tasked with looking at IPC and how the standards are being taken? Do we have our SOPs and guidelines in place? Are we having programs for routine orientation of the healthcare workers, including the cleaning staff and the support staff? Are we monitoring? Is our hospital leadership and our support providing an enabling environment? Are we thinking if we had an Ebola patient today, can we identify space where we keep them, where our supplies and the like, so that at the end of the day, we are all ready to respond? Monitoring and feedback is the key component of IPC because it's the only way we can know that our standards are being followed by all healthcare workers. Several tools like I highlighted here are available that we can utilize to ensure that we have a baseline. We know that this is our gap, so that as we plan, these can be our short-term plans to fill the small achievable gaps like orientation, but these are also our bigger gaps for some of the things that may take time. That can only be done through monitoring and feedback, but also having plans in place in a stepwise manner, really targeted to the gaps. In summary, implementation of IPC measures is in all healthcare facilities, irrespective of Ebola outbreak, but also we can get small gains from things like ongoing orientation of healthcare workers, but also monitoring and supervision of the healthcare workers to look at some of the standards, how they are being performed, and put measures in place to rectify the gaps. There's a couple of MOH IPC resources that were developed in Ebola. Anyone who's interested, we can always go and look at them. The link is provided here, just to keep up to date with the details of the different checklists and SOPs. That's all. Thank you very much. Back to you, Chair. Moderator, that was all from me. Back to you.
Thank you so much for that elaborate discussion. And to our audience, kindly post your questions through the Q&A or our chat to the experts, of course, to respond to them. Our next presenter on diagnostic.
Yes, thank you so much. The previous presenters have made the work pretty easier for me. Clinical microbiologist.
I'll give you 10 minutes.
Yes, I'm a clinical microbiologist from the Department of Lab and Diagnostic, commonly known as CPHL. And we are going to look at the laboratory diagnosis of an Ebola patient. But just like has been highlighted, this is a patient who could have, who could present in a number of ways. So some of the tests may be very specific for Ebola, but some will be supportive. We shall go a little into the pathogenesis and you'll appreciate the reason why, the testing criteria, how do you prepare before you test, how do you transport the samples, how do you manage them, which Ebola specific tests do we do, which supportive tests can we do, and we shall summarize. Next slide. So in as far as pathogenesis is concerned, we know that the virus enters through the mucosal surfaces or breaking the skin, and it replicates in macrophages and dendritic cells, and all these are antigen presenting cells, but it can also replicate in monocytes, and these are found pretty much in many of the body organs. So it then spreads to the lymph nodes, the liver, the spleen, and other organs. And as that the dendritic cells are being embedded, then there will be a suppression to the immune reaction by the body. That's why you see that many times the immune reaction to the body may not, by the body naturally, is inhibited, but the invasion of the macrophages and the monocytes will trigger what we call a cytokine storm or cytokines. So you will get a lot of these reactions, which include the dysregulation of all the coagulation, the blood pressure goes down, you have the bleeding, you have the fever, and you have a disarray of all the immune reactions. Proceed. And this is culminated by organ failure and then sometimes hemorrhage and death. So the testing criteria, we are going to test people who are symptomatic, and this is the rule of the thumb. And usually they present in the first place with high fever, severe headache, and muscle pain. But because these are very unspecific presentations, the reason one of the presenters said, do not rule out things like malaria. So you do the diagnosis, looking at other possibilities that can cause a high fever. But in instances where we are having unexplained hemorrhage, the testing even becomes more valid. And when we have a recent travel to an affected area, contact with infected individuals or clinical and laboratory personnel who are handling these people for the samples. Proceed. So in summary, somebody who meets a test definition should be tested. But before we test, we have a checklist. So we have things that we must make sure we have. We do not want to run into, we are going to have this. So we need protective equipment, and this has been highlighted by Dr. Elizabeth. And then we need to be sure that we have a biosafety level 4 laboratory, or at least an enhanced biosafety level 3. And the enhanced biosafety level is really a laboratory language, but it is about the safety of the patient, the safety of the sample, the safety of the person who is working on the samples. But in this case, the patient does not get to the laboratory. So we have an enhanced BSL-3 that we use in the mobile lab, laboratory that was deployed in Mubende. And then we also have BSL-3s that are situated at least in the reference laboratory, that is at CPHL and UBRI. So the protocols for handling and disposing the biohazardous material, everything that has been around an Ebola patient, you've heard from Dr. Elizabeth, is potentially biohazardous. So you must have a plan. Where am I going to put the remaining blood? Where am I going to put the swabs? Where am I going to put the gloves? Then we have, you must make sure you have the diagnostic kits and reagents. Make sure the person meets the testing criteria. You have a personnel who is trained in sample collection. If you need a partner, please call them on. You might need a patient who is either not, who is not easy to take a sample from alone, or you probably need help. Remember, there are no caregivers in a treatment unit. And then you must have a disinfectant readily available, a plan for waste collection, and you must be knowledgeable about the safe donning and doping procedures. Next. Next slide. Yes, the next slide. Yes, so the recommended, the sample collection, the sample collection will require that the samples we collect will depend on the pathogenicity of the organism, because I've told you that the organism goes to the body fluid. So we can use blood, and we always recommend the use of blood. But other samples like saliva, urine, semen, breast milk have been used. Most PCRs use whole blood in an EDTA bottle, which is our common purple. And the EDTA is important because it helps in stabilizing the nucleic acid. And we always use plastic and not glass, because plastic also interferes with the DNA material that we are looking for. And then it should not contain heparin, that is very key. And when we look at the collection time, it is early at the onset of symptoms, but we usually prefer that it is at least 3 days after symptom onset. But we are not saying wait for the patient to go 3 days. When you take off a sample 3 days, as highlighted in the note, if it is less than 3 days, then you need to take off a second sample, even if the first sample is negative. And this is after 72 hours, preferably, that is 3 days with, of symptom onset. But between the first and the second sample, they should have elapsed at least 48 hours. So you use appropriate containers, which I've already told you they are the purple tops, and you label them appropriately. You do not want to give the wrong patient the right results or the reverse. And then finally, we follow aseptic techniques. You can contaminate the sample and get a lot of artifacts. Proceed. So the sample management, maybe you go back a bit to the recommended slide 6. Slide 6 again. Yes. So this is very key. We use whole blood, like I said, and we need a minimum of 4 ml that is collected in that, in those bottles. However, oral swabs that are stored in universal transport media can be collected from diseased patients or in situations where blood is not easy to collect. For example, in children, you fail to get a vein, and then all you have to do is the oral swab. Swabs from live patients is not recommended due to the lower sensitivity of the reverse transcription polymerase chain reaction and the antigen detection. So we discourage having swabs from live patients. Let's go to slide 8. So in sample management, we encourage immediate transportation of the sample to the laboratory under cold chain. We do not expect samples to be kept at room temperature. And we have a strict chain of custody documentation. This is a sample that is highly infectious, so you do not want to just hand it over to anyone and say, I left the sample. This is not a sample you can give a patient to say the next person will take it away from you. And now in packaging, we use the internationally acceptable transportation guidelines. If it is between, for example, from the ETU to the laboratory, then you can use a double layer where you have the primary sample that is, and you have an absorbent material that is put around it, and then you put it in a secondary container that is puncture resistant and it is also leak proof. But if it is moving, for example, from Mubende to maybe UBRI, then you need a triple packaging. Proceed. So now we go to the Ebola specific test, and the RT or the reverse transcription polymerase chain reaction is semi-quantitative and it's considered a gold standard for diagnosis. And it is also real time. It detects the viral RNA in blood samples, and the whole point is about getting the sample. It has an RNA molecules, and then you multiply them to say the list, or you amplify them as you're seeing in the picture, and then you detect. So it is proven to be highly sensitive and specific, because it is specific to Ebola, depending on the specific type of Ebola, whether it is Zaire or Sudan, and it has a faster turnaround time and very easy to interpret the results compared to other tests that we shall see. Proceed. However, the other specific tests that have not been accepted for diagnosis, because none of them has at least reached 99% sensitivity as per the WHO guidelines. So the gold standard, like I said, is the PCR, but we have other antigen detection tests like the ELISA, which will detect the viral antigen in blood or tissue samples. And this is used in initial screening and confirmation, but the confirmation is in conjunction with a PCR. It has limitations and there's a lot of cross-reactivity considerations, hence the reason we don't use it as a gold standard. And all Ebola subtypes do not have an analyzer antigen yet. That is why we cannot even use it for everyone. Yes, please proceed. And then we also have virus isolation through culture. This is done at BSL-4. However, it is a very sensitive test, but it requires specialized facilities. Like I have said, it is a BSL-4 level laboratory. And it is used for research and confirmation purposes. Really, it is very time consuming and resource intensive. So we do not use it routinely, but it is nice to know that after the virus has been got, it can be cultured. The very way we grow, culturing is like growing or giving nutrients to the virus to grow, and then we can visualize it using an electron microscope. Yes, proceed. And then we also have other serology tests where we detect the IgM and IgG. These are specific for particular serotypes of Ebola, and these are indicated for recent or past infection. They have a role in epidemiological studies and vaccine trials, but they have limitations in acute diagnosis, and we usually recommend that we do this at least 8 days after symptom onset. So again, these are not recommended for diagnosis. Proceed. So having seen what we used to confirm, we also have supportive, like I told you from the pathogenesis, that the Ebola really affects the macrophages, the dendritic cells, and the monocytes. It is very important and prudent to do a complete blood count to monitor the white blood cell count and the platelets. Remember, we are having a discharge, we are depleting the clotting factors. You need to look at your platelets and the white cell count. And normally we get early in the course, we shall get a leukopenia, which is usually a lymphopenia, and then later on we get acute, we get a neutropenia with low platelet counts. But it's also important to look at other coagulation profiles like the bleeding, the prothrombin time, and the INR. Then we also look at the liver function test and the renal, because remember all organs are getting affected because of the storm of the cytokines. So these are very important in patient management and also in prognosis. You want to know, because this is a hemorrhagic disease. Finally, we need to look at the electrolytes and the blood chemistry to monitor the potassium, sodium, and chloride. I know Dr. Kobba told you there was not a lot of derangement in sodium in the last outbreak, but it is not uncommon to have derangements in sodium. You have dehydration, you have electrolyte imbalance, so you need to really check, because the Ebola itself just disorganizes the whole body setup. So you need to be able to give supportive management, because we do not have definitive treatment. You need to look at the blood chemistry to include the glucose, the lactate, and the bicarbonate to look at the metabolic status. Remember, they get metabolic acidosis. And then you can also look at other indicators of organ function. Remember the renal, you can get renal organ failure. So you need to look at all that. And generally, these also are very important in supportive care and treatment decisions. So one very key aspect that we need to look at is how then do we manage samples post-testing. So one, it is very important that after you have tested, you want properly dispose the used material and the PPE. But when I talk about the used material, we're also talking about the blood itself that you have used. How do you dispose it? How do you dispose the everything you've used? Decontamination of work surfaces and equipment. I know this might seem like, okay, it's very obvious, but it is everything that we want to make sure we do not have infection. And then documentation and storage of test results. This is very key. Currently, for all epidemic-prone tests that we do, we have a system which is the result dispatch system. All districts have access to it. It is called the RDS, and also all key personnel in surveillance and epidemic management have access. So these results are entered into the RDS. So it's important that every time you have an outbreak, be it Ebola, any VHF, cholera, you look at how do you store your results. And these results are supposed to be locked, and they're not supposed to be accessed by anyone. including the caretakers. These are results that are given out, but with care, so that you do not cause a disarray. And then finally, compliance with regulatory guidelines for biohazardous waste. This is very key because you find that the waste that is generated is highly infectious, and you do not want to breed another outbreak in an outbreak. So finally, we have looked at the importance of accurate and timely diagnosis, and we can only make it accurate if we test the right patient, we do the test accurately, and then we give out the results in a timely manner, because the results are very, they're needed on time, and that is why we are using a molecular platform that is very fast in terms of giving, and this takes about a few hours to days, depending on what the test result looks like. But really, within 1 day, a patient is able to get the results. Then it is also important to adhere to safety protocols and guidelines. It is not always that the person who takes off a sample will always be a laboratory personnel. Sometimes samples are taken off by the nurses, the doctors, any clinical person who is trained. So it is important that you follow the procedure. But what is even very important is, because you will not always have somebody shout, "I have Ebola." What starts as a simple fever could end up being Ebola, because the case had only a fever and headache and ended up having Ebola. So the important point here is, every time you're taking off a sample, take it off knowing that this is a potentially infectious person, and take it off following the right procedure, at least even if you do not know it is Ebola yet. Then integration of specific and supportive tests for comprehensive evaluation. This is very key. When you only look at Ebola and the Ebola tests, you might miss the other supportive tests that can really help a patient. And then finally, it is important to continuously have training and capacity building for laboratory personnel. And we can as well say for all personnel, clinical personnel, in sample collection. We've seen scenarios like in the last outbreak, where people were uncomfortable taking off a sample from a deceased person because they did not feel confident. So you can only feel confident. You can only feel confident if you know you're doing the right thing. So you have the right patient, you know the procedure, you know what you need, you adhere to the standard precautions, and then you also know where to send the sample and what to use. Thank you so much. Maybe one thing I needed to confirm, to highlight is, we have 2 types of PCR. We have the one which we use for diagnosis, which is the semi-quantitative, the qPCR. But then we also have one for viral load, which is a ddPCR. And studies have shown that these both tests, both PCRs, are very important to determine, one, of course, confirm the disease present, that is especially for the qPCR, but also to determine prognosis. Because, for example, the higher the viral load, the more the likelihood that somebody will succumb to the disease. So these help, and they are used together to compare. So thank you very, very much. And I would like to answer or respond to any questions. And this material will be provided by the organizers of the webinar. Thank you so much, and over to you.
Thank you, Dr. Saudah, for taking us through the diagnostic procedures that are done in an outbreak when you have the VHF patients. She has emphasized on following the standards. For your questions, just post through the chats or the Q&A. She'll be able to answer them, and other experts. We still have one more presentation, and the next presenter will be joining us online. That is Dr. Oumo. Kindly, Dr. Oumo, you're most welcome. Kindly unmute yourself, and you have to first introduce yourself to the.
Right. Thank you so much, moderator. I don't know if I can be heard.
Yes. You're audible enough?
Thank you so much. So we're going to share something about EMS transport and management of EVD patients specifically, though the highlights are more to all VHF patients. The slides are crowded. I thought I would make them summarized, but all the same, we'll share some information. Most of the details have actually been highlighted, and especially education and training, which is key for response, especially to this highly infectious disease. So the person should be highly educated, but also trained, like Elizabeth highlighted. IPC training is quite key for the response. Then we'll talk about the roles and responsibilities. Kindly go to the next slide. We'll talk about everything of this, but in a summary form. And so education is mainly a big and so complete competence-based training with special attention to donning and doffing. It's quite key for even EMS personnel. And we can't state further on terms of tenets of infection control. And please pay careful attention to compliance, because any lapse, even minor ones, cause infection and it could be dangerous to both the patient and also the health worker. Next slide. So in the roles and responsibilities in terms of EMS across the country, we have EMS is at operational level is headed by a commissioner, emergency medical services. And then we have a national coordinator for ambulance response. Then we have regional EMS coordinators. And then eventually we have at regional level, regional referral level, we also have the medical dispatches or dispatchers at these are supposed to be housed at the regional level, and then we have call agents, and eventually we have the foot soldiers, the ambulance teams across the country. Kindly note that what is shown in this picture may not be what is applicable, but what happens is that we have a minimum of at least 4 members that are composed of the team that are keyed for transfer of these highly infectious VHF patients. And one is mainly about supervision, and this is usually the emergency medicine physician, and this provides oversight of patient care, but also manages clinical communication between the transport teams and the receiving facilities, providing clinical decision-making, but also directing, providing medical control, especially where some interventions that might require branching to a nearby treatment unit, as highlighted. Let's go to the next slide. So there are a number of roles each of these persons play. Specifically, I wanted to highlight the one of medical dispatch. And at the moment, this is headed by regional EMS coordinator across the country. So for you to have a patient evacuated, kindly link up with the regional EMS coordinator. And the tasks that are not limited include calling the referring clinician or the patient contact, especially concerning the transfer, and then triaging and determining the care needs of this patient, and therefore preparing appropriately with the referring team. And so therefore, even when they are preparing, triaging and determining needs for the patient care are quite high in the agenda for the medical dispatcher. And also therefore he selects and notifies the destination facility, and then selects appropriate skilled ambulance team that will be able to support transfer of these patients. He also obtains, or he or she obtains, updates on the patient clinical status from the ambulance team, especially when they have arrived on scene, and this influences the continued communication between the team, the receiving facility, and also the medical control. And then liaises with different ambulance teams, but also facilities in case there is need for support, especially when the patient is being moved. And then updates the facility receiving the team concerning the patient status, but also expected time of arrival. So it is important that all alerts are channeled through the, Dr. Elizabeth highlighted the 6 767 code where you SMS alert. And so this is alert management at the moment for those in between the outbreaks. In the outbreak, we shall establish a specific alert management desk where this alerts to be routed to and therefore verified and validated. And then the cases will then be transferred to EMS, and then the regional EMS coordinator therefore dispatches for a specific ambulance as indicated as part of his roles. Next slide. So vehicle preparation is something high that is quite key as well. And the team should learn that we need to prepare ambulance in advance, but also this facilitates the decontamination and disinfection after the patient has been moved. So we know that the ambulance should have a separate patient cabin, but also a different driver cabin, so that the driver cabin is always considered clean. And so we therefore make sure you use an ambulance that has a clear demarcation that separates the patient cabin and the driver's cabin. And there are clear guidelines shared by Elizabeth, especially on IPC preparation of the ambulance for patient evacuation, but also later on as we talk of disinfection and decontamination, we'll highlight this. Vehicle preparation also includes providing equipment and supplies and medical drugs that are required for patient transfer. So high in the list is the oxygen if needed, you have glucose, you have IV fluids that are clearly indicated, even ORS for that matter, that we need for this category of patients. Next slide. So then we do patient preparation, and in patient preparation, when we're in Mubende, some of the patients were ambulatory. Most of them were actually ambulatory. However, some were non-ambulatory, and in some cases we were forced to limit contact. We asked the patients to open the ambulance for them, then they eventually entered into the ambulance. But also in other settings, these patients are actually asked to wear a suit that has a mask and gloves if they can tolerate. And this is where the patient is transported in. If the patient has large volumes of diarrhea, they are also then asked to wear an undergarment, which then is leak-proof, so that they are not able to soil the ambulance. Ambulatory patients, we have to support them and transfer. Sometimes even with the help of a driver, if the team is composed of 2 people only, then the driver should also wear appropriate PPE and support transfer of this patient in terms of preparation. Next slide. Next slide, I'm not seeing it, sorry. All right, so healthcare worker, PE has been highlighted by Elizabeth, and there are different levels. Just the previous slide first, and there are different levels, and this varies by. So the PPEs must be done properly, but also it must be in the presence of a trained observer who then will guide on the appropriateness of the donning. But also you need to include aerosol protection should there be need to do a procedure which could be aerosol producing. And then also PPE, like Elizabeth highlighted, are varied, and there are different types, but specifically for EMS personnel, these are determined by the needs of the patient, and this is highlighted in the next slide. Go to the next slide. So it is important that we implement to meet the exposure to blood and infectious fluid, and patient contact should be limited as much as possible to the least number of persons required to provide care for this patient. And most often we ask that if the patient can support self and enter into the ambulance, this frees up the driver, and the driver then focuses on communication and provides support. But the transport team should also be careful, especially in terms of information sharing. In the setting where you're communicating through a radio call, the information should be carefully tailored such that you prevent leakage of information, private information, health information that can be used in an erroneous manner. The team leader and the EMS physician support the mission by managing communications and logistics, but also we ask that this should not work in isolation with the medical call and dispatch, because when we run out the needs, the caller My apologies, I kind of dropped off I received the call on my device, which interrupted the network, but I was requesting we go to the next slide because we had shared about this. Okay, and so in terms of contamination infection ambulance, it is taught that we isolate the driving compartment.
Yes.
The driver compartment, and then application of impermeable. These are some of the theoretical things that we proposed, but what happened is that the driver compartment should be separate from the patient cabin, and special attention is given to ensure that appropriate contact time for selected disinfectant, especially when you're using, we use chlorine, and chlorine actually caused a lot of corrosion to the equipment. We asked the team that contact time for chlorine should be reduced as bare minimum. And then the procedure of doffing of PPE, this is more practical. I think most of us are aware of or have learned this practically. And we know that this should be supervised by personnel who has a similar training, but also has competency in donning and doffing. And so therefore, this cannot be said clearly on Zoom, but we need to practice this more often, especially when we have more practical sessions. And finally, in the next slide, we're looking at, next slide. We're looking at some of the patients that might be under investigation. And please note that this is based on the case definition, and that there are some patients that will come as alert and suspect cases, which might happen across the country. And we know that it is important that we evaluate the patients, and this assists in selecting the appropriate procedures, but also PPE, and complemented by assessment of patients' clinical condition and the risk that the healthcare provider could be exposed to bodily fluids. You remember the doctor who discussed about case management talked about the dry patient and then the wet patient, and the wet patient having a higher risk of greater risk of transmission of infection to the healthcare provider. So therefore, we should be careful, especially when we're transporting these patients from across the country. When we have an alert and we ask a team from across the country to move this, we should take appropriate care to transport in appropriate PPE, but also avoid contamination. So in a summary, next slide. So in a summary, we're saying that this is part of the idea that we should be prepared even in the time of peace, leave alone the war, especially during the outbreak. In time of peace, EMS personnel should be prepared to respond, and we should understand from basic education and competence-based training, especially on donning, but also preparing the ambulance, and then preparing the vehicle, preparing the patient, and eventually providing appropriate care in transit. And so education is quite key and essential for effective standard and transmission-based infection control practice. The foundation of safe care for emergency patients is mainly about providing, when we now have the patient in the ambulance, it's mainly about attending to the basic emergency care that we have taught across the country, the ABCD approach. If there is airway problem, let's solve the airway problem. It could be secretion, suction them. If there is breathing problem, support breathing with oxygen therapy. If there is saturation problem, which was quite common in this case, so these patients needed IV fluids, and fluids were provided across the units. But most of all, please limit the contact time, but also follow. It requires that we implement the administrative policies. That means you have a clear line of command. So if we are instructed to follow this, we do that. And then the work practices are quite key. When we ask you to don this appropriate PPE, we should be able to use it, don it appropriately. And then the environmental controls, and mainly about IPC, and that includes when you have the waste now, that should be taken to isolation facility for control. And so therefore, focused education, training, and supervision are key for preventing cross infection, but also providing appropriate care for all our patients, especially those suspected to have viral hemorrhagic fever. Over to you, moderator.
Thank you so much, Dr. Oumo, for taking us through the transfer of patient with VHF. And I hope our participants have noted the key messages there in your presentation. At this moment, we've run out of time. We shall go ahead and do our post-test. But as we do our post-test, I think I will request two people to ask questions by show of hands. And some of the questions which were through our chats, and our experts have been able to respond to them. But let us continue posting the other questions that we have that are really important for us to know. Kindly ask questions by show of hands as we fill in our post-test. Kindly project the post-test. As we wait for participants to ask questions, I can have one of the experts here respond to one of the questions which may not have been responded to through our chats. Dr. Kobba, do you have any question to respond to?
Not yet.
Yeah, thank you. There's I think Gibson. I know Gibson was one of the team members in Mubende during the response. He was asking for the results for all outcomes for the MVP 134 drug that we used in Mubende. And what I had said earlier was that because of the late presentation of patients and also the long process we went through to get approval from the different bodies in country, that drug was used quite late in the outbreak. Only about 17.5% of patients in that outbreak actually received. And of those 17.5, very few were given early after onset. Therefore, there was really no further analysis to conclude that either the drug works or it doesn't work, because you could not really base on the small number and also the patients presenting late. So some patients, most patients who received survived, some died, but you cannot really conclude on that. Thank you.
Thank you, Dr. Kobba, for responding to that question by Gibson. So at this moment, let's look at I hope everyone has managed to do the post test, and you just go to your screen, click on more, then you answer the questions, then you submit. So at this moment, let's look at the poll questions. The poll, the most answered questions, and project the poll. So any other question experts would like to respond to? So at this moment, if there are no more questions, I would like to thank all participants for joining today's session, and the experts. Thank you very much for all the presentation. It's been very informative, and I hope the participants have taken all the key messages. And as we wrap up, I will request the experts to take us through the take-home message, key messages that they would like our participants to know. I can start from Dr. Saudah.
Thank you so much. Like I said in the presentation, the take-home message one is Uganda has capacity to test for Ebola, and that is very key, both at the national CPHL or UBRI, and we also have the capacity to mount a mobile laboratory in any part of the country and respond to any outbreak, which is, I think, very good progress. But as we do this, let us also consider the other supportive tests that can be done that can also help in patient management, and most importantly, stay safe as you take off the samples and put the samples in the right media, right container, and transport them safely. Thank you.
Dr. Kobba.
Yeah, thank you very much. The last message is for all the healthcare workers to always be vigilant, for especially these acute febrile illnesses that come to our facilities. It is important that all health facilities are aware of which infections are circulating, not only in the hospital, but also in the communities that the hospital serves. Thank you.
Dr. Allan?
Yeah, maybe I will not say much, but like it was mentioned, the biggest milestone is to eliminate infection, eliminate spread of infection, and all this starts with community outreaches, which is also a big part. Treatment, as you treat, you also reach out to the community to stop the spread of infection. And then also, there is also a part we didn't pay too much attention to, because not because it's not important, but because it was not really discussed here, but that is psychosocial health, which is also a very, very important milestone. Thank you.
Thank you. Our online expert, Dr. Liz, are you still there? On IPC?
Yes, I'm here. Thank you very much. Thank you very much. My take home from the IPC for the IPC section is to encourage all of us to always practice the standard precautions, irrespective of risk of suspected infections, and also to ensure that we always do a risk assessment so that we have the right procedures in place each and every single time, because there will always be that one patient before the outbreak is announced that can expose a great number of healthcare workers. And also for healthcare facilities to ensure that we have IPC investments even when we are not in the outbreak, so that we really minimize the risk of transmission of all infections in our healthcare facilities and the communities we serve.
Thank you so much. Dr. Oumo?
Apparently, I'm the host, so so I've had to end so many sessions on the what on my screen. But thank you so much, moderator, for this opportunity. But otherwise, for EMS, we should prepare, and competence-based training is key. And please, if there's an opportunity to train, especially in terms of appropriateness of PPE, that will be shared by Elizabeth and team, but also in terms of care in transit for patients, especially highly infectious patients. Kindly, let's take up this and we learn. And so therefore, it is imperative that we keep minimized contact, but also if care is needed, we use appropriate PPE. And then EMS is command. You must follow protocol. Protocolized care is key for EMS. And so therefore, we ask across the country, let's follow protocols. We'll share with you pre-evacuation checklists. We'll share with you the notification checklists and so many things, including surgical checklists, medical checklists that are required for protocolized care, and such that we're able to appropriately transfer and provide care to our patients that require our services. Thank you, moderator, and thank you, team.
Thank you, Dr. Oumo, for that. And he's representing the EMS department. And in summary, of course, they say early identification and treatment is very important. And as we do all that, our safety is key. So at this moment, let's do the post-test questions. And I hope, have everyone done? Yes, so once again, I thank you all participants for joining into today's eco session. It has been well presented by our participants. I thank them for all the knowledge gathered and be able to share with us here. And now we go to the poll questions. As we do that, of course, it's time for screenshots. Let's turn our cameras on. Yes. Bye. I can see Dr. Ibra. You're there?
Glad to have joined in on the session. Thank you for the wonderful presentation.
Thank you so much. Thank you, everyone.
Thank you.
Thank you. Thank you for the presentation.
Thank you too for educating